Hello, everyone, and welcome to another episode of Heart Success Podcast. This episode has taken a little bit longer than usual just because a lot of things changed. I had a couple of boards back-to-back work. Here I am, 2 weeks after baby, catching up on some of these episodes. So today we'll talk about the European Society of Cardiology meeting that happened a couple of months ago, 3 months ago, and we'll be talking about some of the big trials that came out, some very, very interesting data, some novel therapies in the field. And, if you've listened to some of our previous episodes on how we go over meetings, we commonly do a combination of, Garima and I will talk about some of the big trials where she will go in detail over the results, what it means, give you perspective, and then I follow it up with quick, short summaries on the rest of the data. Try to provide a little bit more than just a punchline. We have Garima Dahiya back on our episode today. So, Garima, welcome. How's fellowship treating you?
Thanks so much, Mehek. It's really great to be back, and I kind of apologize for this long-drawn absence. I think the beginning of the fellowship is a little bit of a steep learning curve. I don't think residency prepares you enough to be, to walk in as a cardiology fellow on day one. But I've had a really supportive environment, so it's been great so far.
Yeah, absolutely. The first year of your fellowship is usually the hardest. So once you get through that, everything else is a lot easier.
And so did you want to get started with the first trial?
Yeah, let's do it. Let's start with the popular Tavi Trial, which basically looked at the effect of single versus dual antiplatelet treatment on bleeding and thromboembolic events after TAVR or Tavi in patients who did not have an indication for long-term anticoagulation. Garima, maybe you can tell us why we needed this study and then describe the study for us.
Sure, Mehek. So the reason this study was kind of needed was, there's a little bit of a heterogeneity and a lack of consensus when it comes to the optimal duration of dual antiplatelet therapy among patients post-TAVR, and more so because this tends to be an elderly age group that's also at high risk of bleeding. It's currently a class, a grade 2B recommendation by the AHA and a 2A by the ESC to do dual antiplatelet therapy for at least 3 months after TAVR. But whether to continue it at up till 6 months, when to switch to a single antiplatelet agent is kind of the purpose of this trial. And this was a randomized parallel group open label trial that was conducted across 17 European sites from 2014 to 2020 that, like you pointed out, basically included patients who did not have an indication for oral anticoagulation. Now, patients who had also undergone an implantation of a drug-eluting stent within the past 3 months, or a bare metal stent within a month before TAVR, were excluded from the study. And the outcomes that the authors looked at, the primary outcomes were basically all bleeding as well as non-procedure related bleeding for over a period of 12 months post-procedure. And the secondary outcomes evaluated were death from cardiovascular causes, non-procedure related bleeding, stroke or MI, as well as death from a composite of thromboembolic events excluding bleeding. So the study hypothesis was that aspirin alone would be superior to aspirin plus Plavix, or dual antiplatelet therapy, for 3 months with regard to the incidence of bleeding, which is the primary outcome, and would at least be non-inferior with regard to a composite of bleeding plus thromboembolic events among these patients.
Okay. And what were the study results?
So moving on to the results, about 690 patients underwent randomization in this study, out of which 343 were assigned to receive aspirin monotherapy and 347 to receive dual antiplatelet therapy. Of these, about 330 in each group were eligible for final analysis. And I think the baseline characteristics of the patients was sort of similar in the two age groups, with a median age of about 80 years in both the groups. The incidence of coronary artery disease was sort of similar, about 40-41% in both groups. Peripheral vascular disease was about 47% in the monotherapy group and 68% in the dual antiplatelet therapy group, so a little bit of a difference there. And history of prior stroke was also a little different in the two groups, with about 5% in the aspirin group and 3.6% in the dual antiplatelet therapy group. So I think the dual antiplatelet therapy group was at a little bit of a disadvantage when it came to peripheral vascular disease. and a little bit of an advantage when it came to history of prior strokes. And with regard to diabetes, it was about 24 to 25% in both the groups.
Okay.
So when we looked at the 12-month follow-up, the bleeding from of any type had occurred in about 50 patients, or 15% of the total study group, among the monotherapy group, and about 89 patients, or 26%, in the dual antiplatelet therapy group. So there was a significant difference between the two, with a risk ratio of 0.57 and with the confidence intervals of 0.4 to 0.7, and a significant p-value of less than 0.001. And this is, of course, to be expected, as the authors had proposed even before going in, that bleeding would, of course, be more in the dual antiplatelet therapy group. And when they looked at the procedure-related bleeding, which they defined as the BARC type 4, and we can maybe discuss that a little bit more later, it was not observed in patients receiving aspirin alone, and it occurred in about 6 patients in receiving dual antiplatelet therapy. So there was a difference in the procedure-related severe bleeding as well.
I see.
And when we looked at the non-procedure-related bleeding, and again, it is, to be expected. It's about 15% in the monotherapy and about 25% in the dual antiplatelet therapy group. And when we dissect this further as TAVR access site bleeding, it occurred in about 29 of 50 patients in the monotherapy group. That's about 58%. And 48 of 90, or about 54%, in the dual antiplatelet therapy group. So I think the results here were kind of what was expected by everyone going into the study.
Okay, so how would you summarize the results of the study?
Yeah, before I kind of move on to the summary, Mehak, I just wanted to point out the other secondary outcome, which most of us were sort of interested in looking at, is what happened with the thromboembolic events in patients in whom we did monotherapy as opposed to dual antiplatelet therapy. Mm-hmm. And here we saw that when we did the non-inferiority analysis, about 23% patients in the aspirin group had the first composite secondary outcome, which was bleeding plus stroke or thromboembolic events, and 31% in the dual antiplatelet therapy group. So this was a significant value. And even when we did a superiority analysis in these two, there was still a significant difference between the monotherapy and dual antiplatelet therapy group. Now, this is when we combined bleeding with thromboembolic events. When we did purely a composite of thromboembolic events, not really focusing on the bleeding, in this, it's with regard to non-inferiority aspirin, monotherapy was similar to dual antiplatelet therapy, but it failed the superiority analysis. And this is kind of where I think the interest lies is, what happens to those patients with regard to subvalvular thrombosis or stroke if you stop dual antiplatelet therapy early. If you like, I can go into the details of the individual thromboembolic events for our listeners. So, if we look purely at, for instance, all-cause stroke, about 17 of our 331 patients had it in the monotherapy group, and 19 had it in the dual antiplatelet therapy group, 19 out of 334. So just a tiny bit of a difference. And again, it stood its ground when it came to the non-inferiority analysis. And when we looked at symptomatic clinical aortic valve thrombosis, 3 patients had it in the aspirin alone group and only 1 in the dual antiplatelet therapy group. Now, the question is, could you say that it's not a significant difference because there's only a difference of 2 patients? But we also have to sort of factor in that we're only looking at 330 patients in both the groups. Would this difference be significant and kind of debilitating if we did, a study on a larger sample? Sure. And I think that's kind of where my concern would lie when we're extrapolating the study to the larger population. So, just to kind of sum up for you here, Mehak, I think this study is kind of in concordance with what we've seen before. Whether we look at, there's 2 other studies that I was able to find on the data review. One was an RT trial, ARTE, which looked at, again, aspirin monotherapy versus dual antiplatelet therapy in 9 centers across Canada, where it was a very similar sort of a design to our current popular Tavi. And here they found a similar result, that there was a lower incidence of bleeding with monotherapy and not increasing the risk of stroke or MI if you convert it to monotherapy as opposed to dual antiplatelet therapy. And the SAT-TAVI was a pilot study in Italy in 2011, where they again randomized about 120 patients in dual antiplatelet therapy versus monotherapy and followed them for about 6 months. And they found similar results as the popular Tavi trial. So I think, to sort of sum up, as an interventional cardiologist, I'd be more comfortable sort of discontinuing dual antiplatelet therapy among patients who are at high risk of bleeding, knowing that I'm not necessarily putting them at a high risk of bleeding, of stroke or MI. But I'm not sure if this by itself would be a reason for me to do monotherapy in every patient post-TAVR.
Yeah, I mean, in some ways, there is clearly a safety signal that favors aspirin. And like you said, from the standpoint of aortic valve thrombosis or subclinical valve thrombosis, which has been a concern within this subgroup of patients, no clear signal either way. I know the number of events was low, which in a way is reassuring that even though with single antiplatelet, you said the total number of patients with some degree of aortic valve thrombosis was well under 1%, I think, if you look at the numbers. So
yeah.
When I first heard the name of the trial, I felt like we covered this trial in the past, and then we did cover another cohort of patients in our discussion when we went through this in March or April earlier this year on the anticoagulation cohort. That was a different study, but in some ways it was fairly similar. Adding an antiplatelet to anticoagulation post TAVR seemed to actually increase bleeding without any clear evidence for thromboembolic event prevention. So, no, this is a very important study. Thanks for presenting that, Dharma.
Sure, and like you said, the clinical applicability in a way just sort of reinforces the beliefs we've had with regard to thromboembolic events and bleeding.
Yeah. So that takes us, I think, to the next study, which for sure I know we've talked about, but it's not this one. It's the LODO-CO2 trial. And I feel like we discussed the LODO-CO trial in our previous discussion when we were talking about anti-inflammatory drugs and ACS. So why don't you get us familiar with this new study?
Sure, Mahek. This is the LODO-CO trial is basically, it looked at the efficacy of colchicine, low-dose colchicine, in reducing the risk of cardiovascular events in patients with clinically stable coronary artery disease. And, this study comes in the backdrop of the LODO-CO1 trial that was released in 2013 and the COLCOT trial, which was released last year, which we kind of discussed during one of our prior talks. The LODO-CO1 trial was sort of a similar design where they included patients with stable coronary artery disease, gave them low-dose colchicine, and compared outcomes with regard to MI or CV death among patients taking colchicine as opposed to placebo. But I think at that point, the study was considered a sort of a weak study because it only had 530 patients. It was considered a low quality study design. There was lack of blinding and placebo control. Compliance was an issue, lack of diversity, early drug continuation, and, sort of unanswered questions with regard to long-term safety of colchicine. Because of that, the original LODO-CO study kind of flew under the radar and didn't really go a long way in changing guidelines. And in the backdrop of the LODO-CO1 study in 2013 came the next one, which was the COLCOT trial released last year, where we looked at the efficacy of low-dose colchicine in patients who had suffered a recent MI. And that's where we found a benefit of low-dose colchicine in reducing CV death. And in that backdrop now comes the LODO-CO2 trial, which was an international multi-center double-blind event-driven trial in which they randomized about 55-22 patients with stable coronary artery disease who were tolerant to colchicine during a 30-day run-in phase to either randomized to either low-dose colchicine of 0.5 milligram daily or a matching placebo on a backdrop of optical medical guideline-directed therapy. So the inclusion criteria was, patients of 35 to 82 years with evidence of CAD either on invasive coronary angiography or CT or a CAC score of more than 400 and a clinically stable condition for over 6 months. And patients who, either had a contraindication to colchicine in the form of moderate to severe renal impairment or severe heart failure, severe valvular disease, or known side effects from colchicine were excluded from the trial. The primary outcome of the study was event of CV death, spontaneous MI, stroke, or ischemia-driven revascularization. And there were a whole array of secondary outcomes looked at, but one of the key ones was the composite endpoint of CV death, MI, and stroke. So would you like me to just move on to the study results as well?
Yeah, I think so. Yeah, absolutely. Very interesting study. And like you said, the anti-inflammatories are really in right now in coronary disease. So please tell us what the study showed.
Sure. So the mean age of the patients in the two groups was sort of similar. It was about 66 years in both the groups. Point to note was there was only 16% women in the colchicine group and 14% in the placebo, so very poor female representation. Yeah. And about 11% patients were smokers, about 18% patients were diabetics. And this was sort of the baseline characteristics. With regard to chronic CAD, about 99% patients were either taking an antiplatelet or an anticoagulant. About 96% patients were taking a lipid-lowering agent. About 62% patients were on a beta blocker, and about 71% patients were on a RAS inhibitor in your colchicine group. And the median duration of follow-up here was about 28 months. So coming to our study results, like we said, the primary outcome that was defined as CV death, MI, stroke, or ischemia-driven revascularization. It occurred in about 187 patients, or 6.8% in the colchicine group, and about 9.6% in the placebo group. So a significant difference in the two, with hazard ratio of about 0.7 and a significant p-value of less than 0.001. And this, again, was also consistent with the on-treatment analysis. And when we looked at the secondary outcomes, the hazard ratios were here estimated with the Cox proportional hazard regression analysis. And, irrespective of whichever one we looked at, whether it was CV death, MI, stroke, and they sort of like stratified the primary outcomes into individual outcomes for the secondary analysis. And here the rates of, the first 5 secondary outcomes, which were, which I just mentioned, they were significantly lower in the colchicine group as opposed to the placebo group. Now, what's of interest here, if we kind of extrapolate the results from the Colco trial, is, what happened with regard to the adverse events. And when we looked at the non-CV deaths, they occurred more frequently among patients who received colchicine as opposed to those who received placebo, with an incidence rate of 0.7 versus 0.5 events respectively per 100 person years. Mm-hmm. This wasn't significantly different though. And there were there were similar rates of the other adverse outcomes that they looked at, for example, the hospitalization for infections or pneumonia or GI reasons or gout. These were sort of similar between the two groups.
Yeah, very interesting. So when you look at the primary outcome for the study, could you walk us through the cardiovascular components as to the breakdown? Do you have that?
Sure. So when we looked purely at the CV death, MI, and stroke, it occurred in about 4.2% patients in the colchicine group and about 5.7% patients in the placebo group. If we looked purely at MI or ischemia-driven revascularization, it was about 5.6% in the colchicine group and about 8% in the placebo group. If we look at either MI or CV death, it's a further breakdown. It's about 3.6% in the colchicine group, about 5.5% in the placebo group. And if we look purely at the ischemia-driven coronary revascularization, it's about 4.9% in the colchicine group and about 6.4% in the placebo group. So even when we kind of break it down one by one for the sake of our secondary outcomes, we can see that the hazard ratio is significantly lower for colchicine as opposed to placebo.
This is a very interesting study. Maybe you could summarize how the authors presented the study results.
Sure. And, just before summarizing, just a couple of limitations that I did want to point out is there was, we saw that the adverse events were a little bit similar in the two groups, but just a point to be noted that about 15% of the patients did discontinue the drug that's colchicine because of side effects, and they were basically just excluded in the run-in phase. So we may have actually missed a significant proportion of side effects because we already had excluded those patients to begin with. And again, the one thing that did stand out was the low female representation in the trial. So, about the applicability at large. So, just to kind of sum up for us, colchicine did improve CV outcomes among patients, whether we look individually at CV death, MI, stroke, ischemia-driven revascularization. The overall adverse events were similar in the two groups, with a slight signal towards higher adverse events or higher non-CV mortality with colchicine. I think we may have made quite a bit of a headway with regard to this debate that's been ongoing about recruiting anti-inflammatory use as a part of our guidelines, for guideline-directed medical therapy in patients with known coronary artery disease.
Very much. The only thing that worries me about some of this is the actual number needed to treat and the cost impact of using this drug. The number needed to treat, even when you look at Colcott, was quite high. And colchicine, as far as I checked last, remains an expensive drug within the United States because it became expensive a few years ago, of course. So that's something that always worries me with using some of these newer drugs, the actual impact of these drugs, because we don't have great cost analyses accompanying a lot of the study results.
Yeah. And, for me, I think just the biggest takeaway, and I'm really sort of, I am a little awestruck by the benefit of colchicine as an anti-inflammatory, but I'm extremely skeptical still about its side effect profile, irrespective of what we saw here. Just again, because of the exclusion in the run-in phase and the fact that there was a little bit of a tendency of higher, even though it wasn't statistically significant, there was a little bit of a propensity of higher side effect profile in colchicine.
Yeah, no, for sure. That's some caution and continues to grow data on the fact that anti-inflammatories do have a role, and we just have to figure out how we have to pay for the benefit achieved with these drugs. So thanks for that presentation. I think the next study is a very interesting study, a little bit of maybe unexpected results as well, if you may say, and maybe even a win for rhythm control after a long, long, long time. So why don't you tell us about the East Afnech 4 study?
Sure, Meg. Like you said, this was, again, one of the most sort of sought-after results during the recent ESC conference. And this trial looked at the effects of early rhythm control therapy in patients with atrial fibrillation. And, this debate about rate control versus rhythm control has been, I think it's existed for decades now, with the whole array of trials that have preceded the East Afnech. And before walking us through this particular study, I'd just like to bring up those trials really briefly. And I think the three that come to mind are the Affirm, the Afchf, and the Cabana Trial for rhythm control. The Affirm trial was the first one, first major trial in 2002 that looked at rate versus rhythm control. And it, for its primary endpoint, looked at the overall mortality, where unfortunately more deaths occurred in the rhythm control group, but it wasn't a statistically significant difference. And the rates of the composite outcome was similar in the two groups, but it was not a win for rhythm control at that point because of the adverse effect profile. whether it was heart failure, pulmonary, GI, bradycardia, QT prolongation, any of those side effects were more common in the rhythm control group. 6 years after that came the Afchf trial in 2008 in the New England Journal again. And this one, again, the hypothesis was rhythm control strategy would reduce death from cardiovascular causes in patients with Afib and here coexisting CHF. So they enrolled patients specifically with CHF, with EF of less than 35%. And again, targeted rhythm versus rate control strategy. The primary outcome, which was death from cardiovascular causes, after a mean follow-up of about 37 months, there was no significant difference between the two. And here, rhythm control was achieved with cardioversion or antiarrhythmics. So following that came the Cabana Trial last year in 2019 that looked at ablative therapy for rhythm control as opposed to medical therapy for rate control. Those were the two arms. And here again, there was no difference in the primary outcome, which was death, disabling stroke, or cardiac arrest. And in the secondary outcomes, which was mortality or CV hospitalization, there was a significant difference in the ablation group. But again, it did not sort of turn around the opinions of the critics with regard to rate versus rhythm control. And in this sort of backdrop comes the East Afnech trial this year, which was an international parallel group randomized, open, blinded trial that included patients with recent onset Afib. And what I mean by that is patients who had less than 12 months of Afib and had at least one of the following criteria, which was they were old or age more than 75, had history of prior TIA or stroke, or they had coexisting CHF or diabetes, hypertension, CKD, or LVH. And here the trial interventions, basically the patients were assigned into 1:1 ratio of early rhythm control versus usual care. And the rhythm control here was chosen per the current guidelines. It wasn't mandated that it would either be ablation or cardioversion or antiarrhythmics. It basically was protocol guided with regard to the current existing ESC guidelines. And patients were asked to transmit single lead EKGs twice a week or when they were symptomatic. And all of these recordings were forwarded to the study site to monitor how these patients, what kind of a rhythm they were in. And if these patients were having recurrent AFib-triggered episodes, then they would escalate rhythm control strategy as needed. So in the usual care group, patients were treated with just rate control strategy without, incorporating any rhythm control medications. So the outcomes here, the primary outcome was a composite of cardiovascular causes, hemorrhagic or ischemic stroke, or hospitalization for heart failure or ACS, and they were analyzed in time to event analysis. And the second primary outcome was a little bit unusual. It was the number of nights spent in the hospital per year. And the other secondary outcomes basically looked at, it just dissected the primary outcome, each component of it individually by looking at cardiovascular death or stroke and so on. They also looked at the LVEF, the quality of life, AFib-related symptoms, and the cognitive function. And the AFib-related symptoms were kind of monitored by the EHRA scoring system, EHRA being the European Heart Rhythm Association. Mm-hmm. They also looked at the safety outcomes, which is a composite of death from any cause, stroke, or a pre-specified adverse event from the known rhythm control medications. So these patients were followed up from randomization until the end of the trial or death, or if they'd withdrawn. And every 6 months, these questionnaires would be mailed to them to obtain information. And then at 1 year and 2 years, respectively, they'd have EKGs and in-person interviews.
Yeah, no, I like the one where you keep them out of the hospital. That's a huge quality of life impact, keeping them out of the hospital. So let's talk about the results.
Sure. So, under the assumption of an event rate of 8% in the control group and a recruitment time of about 48 months, and factoring in the loss to follow-up as well of about 5%, the authors calculated a sample size of about 2,800, 2,810 needed to show their outcomes. And of these, they were actually successful in enrolling about 2,790 patients across 135 sites in Europe and European countries from 2011 to 2016. And of these, about 1,395 patients were randomized to the early rhythm control group and about 1,394 to the usual group. And patients were enrolled at a median, and this is impressive, 36 days from the diagnosis of Afib. The patients, just kind of going over the characteristics also, most of the patients in the usual care group were either on beta blockers or digoxin for rate control. But other than that, clinical characteristics were sort of similar in the two groups. And most patients in both the groups were also on anticoagulation.
Yeah.
So when we looked at the early rhythm control strategy in the two groups, about 94% of the patients who were randomized to early rhythm control group received some form of antiarrhythmic treatment. Whether this was, if you want me to break it down, about, 35% patients received flecainide, for instance, for rate control. About 20% received amiodarone. Others received propafenone and dronabinol and, ablations. And about 15% patients had a triggered visit to adapt a rhythm control strategy. At the end of 2 years, about 65% patients who were assigned to this rhythm control strategy were still receiving rhythm control medications. And this is in a stark contrast to the rate control strategy or the usual care group, in which initially about 95.8 or 96% patients had Afib managed without rhythm control. And at 2 years, 85% patients were still not receiving rhythm control therapy. So I think the stark difference between the two groups is pretty impressive here. When we looked at how many patients were in sinus rhythm based on this EKG monitoring, about 85% patients were in sinus rhythm at 1 year follow-up and 82% at 2 year follow-up in the early rhythm control group. And about 65% patients at 1 year and 60% at 2 years in the usual care or the rate control strategy group. So looking at our primary outcomes, after a median follow-up of about 5 years, the first primary outcome, which was, a composite that we discussed of CV death, disabling stroke, and so on, it occurred in about 249 patients assigned to the early rhythm control group, which is about 3.9 per 100 patient years. And it occurred in 316 patients assigned to the usual care group, or 5 per 100 patient years. And this was a significant p-value of less than 0.005. And when we looked at the second primary outcomes, that is when we looked at purely at the mean number of nights spent in the hospital, there wasn't a significant difference between the two groups. Moving on to our secondary outcomes, when they dissected it to look at LVEF, or when they looked at cognitive function, it was sort of stable between the two groups. When they looked at quality of life, surprisingly, there wasn't a change from baseline in both the groups. And when they looked at how many patients, the reported feeling of being free from Afib was also similar in the two groups. But I think irrespective, this is a really big win for rhythm control, just seeing that their primary outcome, which was a composite of cardiovascular death and disabling stroke or pre-specified adverse events from rhythm control, it was significantly different in patients in whom we adopted a rhythm control strategy.
Yeah, this is very interesting. A firm made a lot of mistakes. One was, I think we felt confident that rhythm control would come out on top because it would make sense. Keeping people in sinus rhythm is better than letting people remain in AFib. And it was a little humbling, I think, back then when there was a signal for harm, actually, among the patients who received antiarrhythmic strategies. Mm-hmm. One of the things we learned in a firm is when people were put on rhythm control, the actual study investigators and then I guess the folks involved in the study actually took a lot of their patients off of anticoagulation under the assumption that you took the AFib away, you take the stroke risk away. We've learned even through a firm and since that is no longer the case. The anticoagulation really is non-negotiable. And even though there's some questions on pill in the pocket approach for anticoagulation for certain populations. Really, that does not apply to a large majority of the patients. So I think they did the right thing. They caught the patients early. Tried to avoid the issue that came up in Affirm where enrollment was difficult when people had more aggressive forms of AFib. I don't think they were enrolled into the study too. So very smart design and really helped to establish a place for rhythm control today. So maybe you could, tell us a little bit more about if there's anything else about the trial you want to add and the final conclusions.
Yeah, so, I think just not to be the cynic again, but I always like to acknowledge the limitations. One of them being open trial design. Of course, the physicians involved were aware of which patients eventually ended up getting ablations, for instance, or were on antiarrhythmics. And the trial was not designed primarily to assess the safety and efficacy profile that we talked about. It was more to target the primary outcome. And I think the biggest limitation for me here is that this trial, the results are still not applicable to patients who've had AFib for a long time, and only to patients, as you remember, the median onset, the time of randomization was 36 days in the trial. So I think that's the biggest drawback here. And another one I think that sort of comes to mind is they did not look at patients' echo findings to suggest chronic AFib, like for instance, their left atrial size. So I think other than that, like you said, it's a beautifully designed trial, a big win for the rhythm control strategy.
I certainly believe strongly in patients with heart failure and reduced ejection fraction, and even some patients with HuffPEF who are particularly symptomatic. Keeping them in sinus rhythm seems to clearly have a positive effect on their quality of life. And unfortunately, I don't think we'll ever get a study following these patients for 15 years, but you will see this. There are patients who've been in AFib for a decade of their life, some of them reaching 15, 20 years, and they've been in AFib the whole time. They didn't start out with heart failure, but a lot of these folks will develop new heart failure. Anecdotal, but concerning signal when you're in AFib for a long time. So I still hope that we continue to build around this data, but I think keeping people in normal sinus rhythm and as safely as possible seems to be the way to go in a lot of these folks.
Yep, absolutely.
Thank you so much, Garima. That was great.
Yes, it was a pleasure being back on the show, Mehak, and hopefully I'll be back sometime in the future again to walk our listeners through maybe some more trials or some other interesting clinical questions.
Yeah, absolutely. See you soon.
So let me go to Explorer HCM next. Explorer HCM basically stands for mavacamten for treatment of symptomatic obstructive hypertrophic cardiomyopathy, a randomized, double-blind, placebo-controlled phase 3 trial. Lead author is Jacopo Olivoto from Italy and has multiple authors across multiple continents, published in The Lancet around the same time as presentation at ESC. You want to get to know this drug a little bit better because it is completely new. If you haven't heard about it before, don't be surprised. It is the first drug in its class. It's called mavacamten, MAVACAMTEN. It is a small molecule that is a selective allosteric inhibitor of cardiac myosin ATPase, specifically developed to target the underlying pathophysiology in HOCM by reducing actin-myosin cross-bridge formation, thereby reducing contractility and improving myocardial energetics. In the preclinical and early clinical studies, Pioneer HCM was a phase 2 open-label study where this drug was studied, showed significant reduction in post-exercise LVOT gradients in obstructive hypertrophic cardiomyopathy, some evidence of improved exercise capacity and NYHA class improvement. So on the basis of these results, this is a phase 3 trial. It was multi-center, randomized, double-blind, placebo-controlled, parallel group, performed in 68 centers in 13 countries. So let me start with who was studied, and I think this is the most important part of this trial. The inclusion criteria basically had folks that were 18 years or older with a diagnosis of obstructive hypertrophic cardiomyopathy, further defined as unexplained LVH or LV hypertrophy with maximal LV wall thickness of 15 millimeters or more, or it could be 13 millimeters or more if you had a familial hypertrophic disease. Peak LVOT gradient at least 50 millimeters at rest after Valsalva or exercise. It could be either one of them. The LVEF was at least 55%, and patients were NYHA class 2 or 3 symptoms. Additionally, to gain entry, they had to be able to safely perform an upright cardiopulmonary exercise test. So a very selective group of people with an obstructive phenotype, LVOT obstruction, people that were healthy enough and strong enough to undergo a CPAT, which is the cardiopulmonary exercise test. It's also important to know who was excluded from the study. Those with a history of syncope or sustained ventricular tachyarrhythmias with exercise within 6 months prior to screening were not allowed. Those with a QT interval of more than 500 milliseconds calculated by Friederichia formula were not allowed. Paroxysmal or intermittent atrial fibrillation present on screening electrocardiogram, and persistent or permanent Afib not on anticoagulation for 4 weeks or more, or not adequately rate controlled within the 6 months prior to screening were not allowed. Additionally, those who underwent septal reduction therapy more than 6 months before screening were enrolled if otherwise eligible. So you had to be at least 6 months out of either an alcohol septal ablation or standard or your myectomy, surgical myectomy. They also did not allow their patients to be on disopyramide for safety reasons. And, it's a known therapy for patients with hypertrophic obstructive cardiomyopathy. The study was industry funded by Myocardial, which is a Bristol-Myers Squibb company. And several of the authors had financial disclosures associated with this company, among others. Let me start by telling you that it was a positive study, and it was not a study that looked at hard outcomes or hard endpoints like mortality or even heart failure hospitalization. They looked at changes in your peak VO2 on cardiopulmonary exercise test as your primary endpoint, and then had several secondary endpoints, which included some functional parameter changes and functional class changes, which I'll go into. Between May of 2018 and July of 2019, 429 patients were assessed for eligibility. Roughly 60% were enrolled, a total of 251, 123 randomized to mavacamten, 128 randomized to placebo. The primary endpoint was a 1.5 ml per kilogram per minute or greater increase in peak VO2 and at least one NYHA class reduction, or a 3 millimeter per kilogram per minute improvement in peak VO2 without NYHA class worsening. So you could have either or. Secondary endpoints were changes in post-exercise LVOT gradient, peak VO2, NYHA class, the KCCQ clinical summary score, which is a Kansas City Cardiomyopathy questionnaire, and also a HCM SQ SOV, which is a hypertrophic cardiomyopathy symposium questionnaire, shortness of breath subscore. What they found was patients on mavacamten had a greater reduction than those on placebo in post-exercise LVOT gradient, a difference of minus 36 millimeters of mercury. They had a greater increase in peak VO2, 1.4 overall difference, and improved scoring systems, both KCCQ and HCM-SQ were improved. 34% more patients in the mavacamten group improved by at least one NYHA class. And if you look at the absolute numbers, it was sort of 2/3 versus 1/3 had improvement in the study group versus placebo. Safety and tolerability were similar to placebo for the drug. Treatment emergent adverse events were mild. And there was one death by sudden. There was one sudden death in the placebo group. When you look at how many patients achieved the primary endpoint of the peak VO2 change, either 1.5 or 3, plus or minus the NYHA class improvement, it was 37% in the study group versus 17% in the placebo group, p-value of 0.0005. Roughly a quarter of the patients in mavacamten had at least a 3 millimeter increase in their peak VO2. 1/5 or 20% had improvement in both NYHA class and improvement in peak VO2 by 3 or more. These numbers were roughly 2.5 times what was seen in placebo. Fairly impressive results. I think this is a drug that is here to stay. The number of adverse events were actually much lower in the study group than the placebo group. None of them really seemed to be directly related to the drug itself. Interestingly, there were 2 cases of stress cardiomyopathy in the mavacamten group, none in the placebo group. During the overall follow-up of the study, which was 30 weeks, there were 5 patients, 3 in the mavacamten group and 2 in placebo, that had a protocol-driven temporary treatment discontinuation for a drop in LVEF of under 50%. So this is something that may be seen in some patients with mavacamten. You may see their EF drop just a little bit. All these people had normal EF to start with. It works by reducing actin-myosin cross-bridge formation and reducing contractility, so it's expected that in the treatment arm, you would see a decrease in ejection fraction to a certain extent. We don't know that is harmful. Great news is that there is an ongoing long-term extension of the study that will provide further evidence for clinical benefit and safety of mavacamten over 5 years. So you will hear more about this drug. I think the major limitations of the study were that they excluded disopyramide, which is an established drug that may be second or third line in patients with symptomatic hypertrophic obstructive cardiomyopathy. They also excluded patients with NYHA class 4 symptoms. However, both these are going to be studied in a VALOR HCM study. So that may put some of these problems to rest. There weren't a lot of young people in this study. Mostly people in their late 50s, 60s were included in the study. The breakdown for male to female was favoring men. Looks like probably close to 60-40 or so. More men than women in the study. And 40% of the patients were from the US. Rest looks like were from other centers, a lot of them in Europe. 30% in both groups, close to 20 to 30% in both groups had a pathogenic or likely pathogenic gene variant. The amount of patients that had actually undergone septal reduction therapy was quite low. It was single digits. It was 6% in the placebo, 9% in the treatment arm. So very few people had actually undergone corrective surgery or alcohol septal ablation. And beta blocker, of course, was the main drug used in close to 3/4 of the patients, and then calcium channel blockers were used in the other 15-20%. Roughly a fifth of the patients had a defibrillator in. So this is sort of the group of patients that were studied. I think this is where the data applies. You can't use it in patients who have a non-obstructive HOCM phenotype. The other thing which we know in HOCM is that postprandial obstructive gradients are usually much higher, even with resting and exercise, and that was not part of the protocol. So chances are that the gradients that they mentioned in this study could have been a lot higher if they were done postprandially. That's what I'll leave this at. We have no evidence for hard outcomes. We have clear evidence for improvement in functional class, improvement in functional capacity, improvement in maximal and submaximal exercise capacity, which is actually great. No evidence for hard outcomes, no evidence for whether this changes arrhythmias, causes more arrhythmias, and time will tell. I think it's a very important drug that is here to stay, and you'll hear more about it. An interesting trial for discussion was the popular Cabbage Trial. It assessed the effect of adding ticagrelor to standard aspirin on saphenous venous graft patency in patients undergoing coronary artery bypass grafting. It was a randomized, double-blind, placebo-controlled trial. It was an investigator-initiated trial. Now, the role for dual antiplatelet therapy post-Cabbage remains quite controversial. The current guidelines allow you to do it following ACS, but even there, the data is not that great. The data comes from a subgroup of the CURE trial and maybe some retrospective analyses showing advantage to using dual antiplatelet therapy, particularly really Plavix post-Cabbage. I think in practice, there is really no consistent pattern. Most of the cases, if the bleeding risk is low, we will continue Plavix post-Cabbage in the setting of ACS, or if somebody had a recent stent. Now, there is a little bit of data, and this mainly comes from off-pump Cabbage patients, off-pump stable Cabbage patients, that in addition to aspirin, there may be an advantage to using Plavix to decrease the rate of vein graft occlusion. The data is not that strong, and there is no clear standardization in practice. We also know that SVGs are notorious for going down soon after surgery. As many as 15% of the saphenous venous grafts, or SVGs, occlude during the first year after Cabbage, despite being on aspirin. In this study, they randomized patients with more than or one SVG post-Cabbage to receive either ticagrelor or placebo in addition to their aspirin, which was either 80 milligrams or 100 milligrams, which is standard practice. And they looked at SVG occlusion at 1 year using coronary CTA. It was 499 patients, almost 500 patients, mean age 68 years, 87% male. 31% of these patients underwent bypass for ACS, and 95.2% of the surgeries were done on cardiopulmonary bypass, 5% off-pump surgeries. The primary outcome imaging was available with what looks like maybe 10% dropout. And, the SVG occlusion rate was 10.5% in the ticagrelor group versus 9.1% in the placebo group. Odds ratio 1.29, p-value 0.38, so basically no difference. Saphenous venous graft failure occurred in 14.2% of the patients in ticagrelor group versus 11.6% of the patients in the placebo group, odds ratio 1.22. This randomized placebo-controlled multi-center conducted trial basically showed that the addition of ticagrelor to standard aspirin did not reduce SVG occlusion at 1 year after Cabbage. Very interesting results. I think, for patients that if you're arguing adding a second antiplatelet to maintain SVG patency, you are doing so in the absence of any convincing data to show that. And we know that the bleeding risk is high on a dual antiplatelet strategy. So again, individualization of approach, but cannot assume that the second antiplatelet is really adding too much after a bypass surgery from the aspect of saphenous venous graft patency. The next drug I'd like to discuss briefly is the Emperor-reduced trial, which is cardiovascular and renal outcomes with empagliflozin in heart failure, irrespective of diabetes. This is a study that is in many ways similar to Dapa heart failure that we've spoken about previously on several occasions, presented at the ESC of 2019 on Dapa heart failure, which kind of changed the field of heart failure and brought in quadruple therapy at the time. Emperor Reduced is kind of the same trial in some ways, with a different drug in that class or in that category. There's empagliflozin here compared to dapagliflozin in the previous study. The lead author on this paper is Milton Packer, who's brought us a lot of great trials before, including Paradigm for Entresto. So the background is, we believe that SGLT2 inhibitors reduce the risk for hospitalization for heart failure in patients regardless of the presence of diabetes Dapa heart failure also had improvement in all-cause mortality, cardiovascular mortality as well. They studied 3,730 patients with NYHA class 2, 3, or 4 heart failure and a reduced ejection fraction of 40% or under to receive empagliflozin, which is just a flat dose of 10 milligrams daily, versus placebo. Primary outcome was a composite of cardiovascular death or hospitalization for worsening heart failure. There is a median 16-month follow-up, and the primary outcome event occurred in 19.4% in the empagliflozin group versus 24.7% in the placebo group. Hazard ratio 0.75, p-value less than 0.001. The effect on this primary outcome was consistent irrespective of diabetes. Interestingly, the entire difference was driven from a reduction in heart failure hospitalization. When you look at cardiovascular death, it was 10.0% in empagliflozin versus 10.8% in placebo. Hazard ratio 0.92, your confidence intervals crossed the midline. So the entire difference came from hospitalization and heart failure. There were other pre-specified analyses, particularly the one focusing on renal outcomes. And that significantly favored use of empagliflozin with 1.6% versus 3.1% in the treatment versus placebo arm. And the composite renal outcome was chronic dialysis or renal transplantation, or a sustained reduction of 40% or more in the estimated GFR, or a sustained estimated GFR of less than 15 ml per minute in patients with a baseline GFR of 30 or more, or a sustained reduction in GFR of less than 10 in those with a baseline GFR of less than 30. Lots of complicated parameters there, but I think overall it indicates progression of the renal disease. And there is less progression in renal disease among patients who get the drug. All-cause mortality was essentially the same in both groups, 13.4% versus 14.2%. Onset of new diabetes also was sort of similar in both groups among patients with prediabetes. Your A1C dropped by 0.28 in the drug arm versus 0.12 in the placebo arm. Slightly lower NT-proBNP in the treatment arm, and slightly greater weight loss in the treatment arm as well. Both of these sort of expected, nothing major. The weight loss was 0.7 kilograms overall in the treatment arm versus increase by 0.08 in the placebo arm. An interesting analysis was in the subgroup of patients that were receiving sacubitril valsartan at baseline. As we know, this was one of the criticisms of Dapa heart failure, which had a very low rate of Entresto use, roughly 11%. Wasn't much higher in this study. It was, I think, close to 19-20%. But in their forest plots, they showed that patients had an improvement in their primary endpoint, irrespective of whether or not you were on Entresto. So it was a little different from the previous study. The way I look at this study, I know there was a lot of excitement around the results, but all it does is it reduces heart failure hospitalization. Compared to Dapa heart failure, the results are somewhat not as impressive. They are consistent in some ways, with some of the other results of Dapa heart failure, but mortality being no different makes you question. Now, we had Journal Club on this a few weeks ago. One of our fellows presented this study and sort of put it out to the group. And there seems to be no clear answer as to why that's the case. There are some hypotheses. One of the hypotheses is that patients in Emperor reduced were a little sicker than patients in Dapa heart failure. And when you inspect the event rates in the placebo group in both studies, because, in a way that's one way to look at whether there was a big difference, and it doesn't seem to be the case. It just doesn't look that impressive. Some rates are higher in Emperor reduced. for certain endpoints, and the others are fairly comparable. So we don't know why the results are different. However, there are a couple of very small studies which we won't discuss today, but one of them is Empotropism that came out last month in November, I believe, and Sugar DM, which you may have heard of from before, both of them using empagliflozin in patients with reduced ejection fraction. Both of them showed that in addition to using Entresto, which was used in, I think, 30 to 40% of the patients in these two studies, small randomized studies, but adding empagliflozin actually had improvement in LV ejection fraction, reduction in LV end systolic volumes and diastolic volumes. And I think that's what we try to do in a lot of these patients. We're trying to improve LV remodeling. We're trying to improve their cardiac function. To me, I still think the overwhelming data supports using this drug as your fourth drug. Remember, 70% of patients were on an MRA in both these studies. Don't just jump to SGLT2 inhibitors before you've tried that aldactone or at least considered it, which in itself is a fantastic, cheap drug. So the way I use it is I use it in patients as a fourth drug. And before I start it, I make sure that we know the patient can afford it. Because you can imagine the costs for Entresto, the costs for DOACs, the cost for a lot of these other drugs starts adding up. And you come into a place where you may have to pick or choose between one and the other. So until it's a lot cheaper, you will still have to be very selective, I think, in which patients you can start this drug on. The next episode that we're going to do, which we've already recorded, goes over all these different drug classes, and we have a multidisciplinary video conference, which I'll be releasing in a few weeks with cardiologists, endocrinologists, and nephrologists that will tell you a little bit more about what to watch out for with these drugs, how you counsel your patients. So I won't go into that in today's episode. So we'll move on to our next trial. I'm going to talk about the AT-PCI study, which is efficacy and safety of trimetazidine in patients having been treated by percutaneous coronary intervention. This is a new drug. It is an anti-anginal agent that improves energy metabolism of ischemic myocardium. The bottom line was it was a negative study. The AT-PCI trial failed to show that trimetazidine was superior to placebo at reducing adverse cardiovascular events. To summarize this study, it was a big study. It was 6,000 patients followed for close to 4 years. Mean age was around 61 years, 23% female. They studied patients between the ages of 21 and 85 who had PCI for stable or unstable coronary artery disease within the last 30 days. Primary endpoint of the study was cardiovascular death, hospitalization for cardiac events, recurrent or persistent angina, leading to changes in your anti-anginal therapies or coronary angiography. And the results were essentially no difference in both groups, 23.3% in the drug group, 23.7% in the placebo group. No difference in the primary outcome according to elective or urgent PCI. No difference in angina requiring hospitalization. And no difference in the treatment emergent adverse event profile. Overall, I think the conclusion was among patients with a recent PCI, trimetazidine was not superior to placebo at reducing adverse cardiovascular events. The event rate in this study was a lot lower than expected, and that may have contributed to part of why it ended up being a neutral trial. The next study I'll talk about is Parallax, sacubitril valsartan compared with optimized background therapy in patients with HFpEF, which is heart failure and preserved ejection fraction. It was led by Dr. Burkhard Piesk from Berlin and German Heart Center in Berlin. They randomized a total of 2,572 patients with HFpEF, mean age 73%, 51% female, to either Entresto or sacubitril valsartan versus optimal individualized background therapy, which often included enalapril, valsartan, or placebo if they were not taking a RAS inhibitor. mean LVEF in the study was 56% at baseline. The primary trial endpoints were change from baseline to 12 weeks in NT-proBNP, change in 6-minute walk distance from baseline to 24 weeks. They found that patients treated with sacubitril valsartan showed a significant 16.4% greater reduction in NT-proBNP than those treated with optimal individualized medical therapy after 12 weeks. However, this did not translate into an improvement in 6-minute walk distance at 24 weeks. In fact, both groups saw improvements in their walk distance at 6 weeks, roughly 9.7 meters in the treatment arm versus 12.2 meters in the individual medical arm. Quality of life also improved in both groups and was better in the sacubitril valsartan arm at week 4, but again, no difference at week 24. Serious adverse events were relatively similar in both groups except for heart failure events. Heart failure events did occur more frequently in the medical therapy arm, and a post-hoc analysis showed that sacubitril valsartan reduced the risk for heart failure hospitalization by 50%, peak value of 0.005. They also showed that treatment with sacubitril valsartan showed a lower decline in renal function at 24 weeks. So, the results are somewhat consistent with Paragon heart failure. Among patients with HFpEF, that was a neutral trial. The benefit in that study was seen among patients with EF of less than 57% and women. That's sort of the group that was studied here in some ways. But really no further benefit of using sacubitril valsartan in this group with sort of mid-range to preserved ejection fraction. Now, I do believe that if the FDA approves use of this drug is in HFpEF patients, we might start using it just due to the lack of better options. We will wait for data from SGLT2 inhibitors, from cyclic GMP activating drugs over the next few years among HFpEF patients. But as of right now, we continue to be in search of that one therapy which may offer an improvement in heart outcomes. Part of the reason why, as we mentioned before, we continue to fail may be because HFpEF is not really a heart failure problem. It is a systemic problem that involves, vascular stiffening, ischemia, microvascular disease, has inflammatory components to it, and using drugs that have worked in reduced ejection fraction just don't have the profile to be beneficial in a disease that is systemic with multiple different facets to it. So, there may be a subgroup of patients that this may be beneficial in, and in time will tell in how we can better phenotype our HFpEF patients. The next study that we'll talk about is the home PE study. It's called the Hestia rule versus simplified PESI for home treatment of patients with acute pulmonary embolism, home PE. Sponsored by the French Ministry of Health, presented at the ESC Virtual Congress by Dr. Pierre-Marie Roy. I would say right now in the United States, as far as I've seen, all patients with acute pulmonary embolism have been treated inpatient. Some of them have had very short stays. You put them on a direct oral anticoagulant. When they're stable, they can go home, maybe stay a night in the hospital. But I haven't seen a lot of patients just discharged. I have never seen a patient discharged with an acute pulmonary embolism straight from the ER or from the hospital same day. The European guidelines actually recommend the Pulmonary Embolism Severity Index, which is the PESI score, or the simplified PESI score, to assess the risk for all-cause mortality. And if your SPESI score is 0, you can be treated at home, provided a proper follow-up and anticoagulant therapy can be provided. The American guidelines, don't really have clear guidelines, clear direction on how to make this decision, and advise pragmatic criteria sometimes, such as the Hestia criteria. It was a randomized open-label non-inferiority trial comparing two triaging strategies. It was conducted in 26 hospitals in France, Belgium, Netherlands, and Switzerland, which had set up prior to study initiation a thrombosis team for outpatient care of patients with acute pulmonary embolism. So the results of this study were basically that the primary outcome, which is a composite of recurrent VTE, major bleeding, and all-cause death within 30 days, were similar in both groups, whether you use the Hestia group strategy to risk stratify your PE patients or the ESC criteria. Interestingly, a greater proportion of patients were eligible for home care under ESC, roughly 48.4%, compared to the Hestia, which was 39.4%. However, the doctor in charge of the patient overruled ESC more than they did Hestia. Consequently, a similar proportion of patients were discharged within 24 hours for home treatment, 38% in the Hestia group versus 36.6% in the ESC group, p-value of 0.42. All these patients managed at home had a very low rate of complications. So I think this study supports one outpatient management of acute pulmonary embolism using either the Hestia or ESC score, provided the physicians also have the ability to individualize their decision in certain cases when they want to override the risk score deliberations. So in hospitals, I think where we have an organized treatment group or treatment strategy for outpatient pulmonary embolism and outpatient thrombosis treatment, more than a third of these patients can be managed at home with a very low rate of complications, particularly relevant in today's times, when hospital beds are fair and few. I think this study highlights how we need to continue to learn how to improve in providing care, and not all patients need to end up in a hospital. I don't treat as much PE anymore. Naturally, I think my pulmonary colleagues and medicine colleagues would treat it a lot more. So it would be reasonable to ask them if they think the results of this study would change how they practice medicine. I have a feeling that in the American medical legal environment, until this makes it into the guidelines, people may be a little more hesitant than others, but we'll see. We'll talk about BPL-TTC, which is, can BP-lowering medication help prevent heart attack, stroke, regardless of blood pressure levels? This, unlike some of the previous studies we spoke about today, was not a randomized controlled trial. The BPL-TTC researchers conducted a meta-analysis of data from close to 350,000 participants from 48 clinical trials from all over the world. The participants were divided into two groups, those with a prior diagnosis of cardiovascular disease and those without. Each group was then further stratified into 7 subgroups based on their systolic blood pressure at study entry, ranging from either less than 120 all the way to 170 and above. And they had roughly 4 years of follow-up data. The overall results showed a reduction in relative risk of major cardiovascular events by roughly 10% for each 5 millimeter reduction in systolic blood pressure. Risk for stroke, ischemic heart disease, heart failure, and death from cardiovascular disease were reduced by 13%, 7%, 14%, and 5% respectively. So some improvement in all of those criteria, most pronounced when it comes to stroke and heart failure as expected. According to the lead author, there was no evidence that proportional effects varied by baseline BP values down to the lowest BP category of less than 120 millimeters of mercury, be it in the second primary or secondary prevention strategy. So, there are a lot of conflicting guideline recommendations when it comes to what the typical threshold for treatment of hypertension is. In the ACC-AHA guidelines that came out a few years ago, I think maybe 2 or 3 years ago, they had moved to a risk stratification sort of introduction to the idea, and I think that's a reasonable approach to take still today. So, the authors in this, based on the study, suggested that the decision to prescribe BP-lowering medication should not be based simply on a prior diagnosis of cardiovascular disease or the individual's current blood pressure, but use it as a risk-modifying treatment for prevention of incident or recurrent cardiovascular events, regardless of the blood pressure values at baseline. I still think there is so much role for individualization, and there's an art to how you treat blood pressure. You need to incorporate your side effect profiles, your treatment costs, the setting you're in, the doses, the timing of doses. Some data that maybe at night treating blood pressure, giving pills might be better. So there's so many variables to how you treat blood pressure. I think it shouldn't take away from the fact that there is still so many people out there with just untreated or uncontrolled hypertension that we should continue to expand our treatment rather than trying to focus on whether 120 millimeters of mercury is that much better than 125 or 130 millimeters of mercury. We have a COVID randomized study that was presented here, and it handled a very interesting and important question that came up right when we learned more about how the virus gained access, and then it came to light that it was the ACE2 receptor on the endothelial cells that was an entry point for the coronavirus. What did Brace Corona really look at? Brace Corona looked at continuing versus suspending angiotensin converting enzyme inhibitors and ARBs in these patients. The bottom line was that it doesn't matter what strategy you choose. They were both equivalent in the endpoint. So among patients hospitalized with COVID-19 infection, suspending ACE or ARB really did not improve days alive or out of hospital. They studied roughly 660 patients with COVID-19 infection. They were randomized to either temporary suspension of their ACE or ARB versus continuation of the drug. Mean age 55 years, females 41%, third of them had diabetes. All these patients were on chronic ACE and ARB, so that's a selection criteria. They were included only if they were on this drug coming in. And they were excluded if they had decompensated heart failure, if they were Entresto, or they were hemodynamically unstable, or multiple blood pressure agents. They were excluded from this study. And the primary principal finding was that the primary outcome, number of days alive and out of the hospital through 30 days, was 21.9 days in the suspension group versus 22.9 days in the continued group, p-value of 0.09. All-cause death at 30 days was 2.7% in patients that had their ACE and ARB suspended versus 2.8% among those who had it continued, p-value of 0.95. So really no difference in any of these outcomes. So I think this highlights the safety of continuing to use these drugs, in COVID-19 infected patients as long as they're hemodynamically stable. So no reason to discontinue the drug in the hospital. Kudos to the authors for randomizing this group of patients because, a lot of you have probably been part of several discussions on what to do with these drugs, particularly early on when we knew so little about the virus. And I think even the outcomes to a degree were a lot worse for the first few months. Moving on to our next study was the Afib trial, which studied whether single education intervention aimed at increasing the use of oral anticoagulants for stroke prevention among patients with atrial fibrillation made any difference in the actual uptake of oral anticoagulation. The results were presented by Dr. Sean Pokorny from Duke University Hospital. The primary endpoint was the proportion of patients started on oral anticoagulation over the course of 12 months of study. It enrolled patients with AFib aged 30 years or older and CHA2DS2-VASc score of 2 or greater. Participants had not been prescribed an anticoagulant in the prior 12 months and had not been admitted to hospital for bleeding in the prior 6 months. They were randomized to either the education intervention group or the usual care group. And in the intervention group, patients and their healthcare providers received one mailing at the start of the trial. They randomly assigned 47,333 patients, average age of 78 years, to either the educational arm or the usual care arm. The researchers found that at 1 year, the primary endpoint occurred in 2,328 patients, which is 9.9% in the intervention arm, versus 2,330 patients, which is 9.8% in the usual care group. Odds ratio 1.01, confidence intervals equal around the baseline, so cross the baseline. The authors concluded that among the population with a guideline indication for oral anticoagulant for stroke prevention, there was no statistically significant difference in the rates of oral anticoagulation initiation at 1 year with a single education intervention. They did notice that numerically a lot more patients started the oral anticoagulant early after the mailing, raising the question whether multiple mailings or further contact may have been beneficial. I think it's quite impressive that the rate of initiation of anticoagulation in this group of patients that has a clear guideline indication was still under 10%. So lots of work to do there, where we need to expand appropriate use of this drug across patients and participants that would benefit from an oral anticoagulant and reduce future strokes. The next study is a randomized trial of transfusion strategies in patients with myocardial infarction and anemia. Reality. I like the name. This trial brings redemption to all those of us who have continued to argue that you can get away with lower hemoglobins in relatively stable patients post-MI. Because I've dealt with far too many people that have wanted a very liberal transfusion strategy post-MI and aim for much higher hemoglobins. So what is the conclusion of the trial? The trial concluded, Reality trial concluded, that a restrictive PRBC transfusion strategy, transfusion for less than or equal to 8 grams per deciliter, aiming for between 8 and 10, was non-inferior to a more liberal transfusion strategy of less than or equal to 10 with a goal hemoglobin of more than 11. The trial was presented by Dr. Philippe Gabriel Stagg, and they randomized patients, 666 patients, followed them for 30 days, mean patient age 77 years, 43% female, who had an MI at admission. It was either an NSTEMI or a STEMI. And the last ischemic symptoms were less than 48 hours before admission. All of them had a troponin elevation. And then patients had an anemia with a hemoglobin of 10 or less, but it was more than 7 at any time of index hospitalization for MI. They excluded cardiogenic shock. They excluded bypass. They excluded recent transfusions, active hematological diseases, or massive bleeding. So some of these people were not part of the trial, and appropriately so. Roughly 70% of the patients had an NSTEMI, with 80% of the patients receiving coronary angiography, 59% receiving PCI, and 4% eventually did end up getting Cabbage. Mean units for PRBC transfusion per patient in the restrictive group was 2.9 versus 2.8 in the liberal transfusion group, so not that much of a difference. However, at least one unit of PRBC transfusion was significantly lower in the restrictive arm, with 35.7% of the patients versus 99.4% in the liberal transfusion arm. Makes sense. The primary outcome of all-cause death, reinfarction, stroke, and emergency revascularization prompted by ischemia was 11% in the restrictive arm versus 14% in the liberal transfusion arm, hazard ratio 0.77, p-value less than 0.05 for non-inferiority. The restrictive strategy was not superior with a p-value of 0.22. All-cause mortality was lower in the restrictive arm with 5.6% versus 7.7%, p-value more than 0.05. Recurrent MIs, emergency revascularization, numbers were quite low, both of them quite similar in both groups. When it came to some of the secondary endpoints, no difference in acute renal failure, slightly higher risk for infection in the treatment in the group that received more transfusions in the liberal group, but the absolute numbers are really low, 0% versus 1.5%. Acute lung injury was more in patients that received more transfusions, 1.9% absolute difference, and then length of stay, no difference. Total hospitalization cost, really not that different, but trending towards greater cost among patients who had more transfusion. So the interpretation of this trial was that a restrictive PRBC transfusion strategy, aiming for 8 to 10, and really transfusing for less than or equal to 8, is non-inferior to the more liberal strategy where you transfuse for less than 10 and go for over 11 grams per deciliter. Additionally, there was signal for harm with more infections and acute lung injury with the more liberal strategy. Total blood utilization and costs were lower in the restrictive strategy, and this strategy was cost dominant, as the authors called it. I think it's an important trial. In a way, it probably changes how we practice transfusion in the peri-MI period. I think usually in my practice, I've always looked at 8.5 as where you want to pull the trigger, as long as they're not having active ischemia. I think that's a very reasonable question. It doesn't answer the question whether you can go as low as 7, which I know is often what we'll do in outside of MI, and that just needs to be studied further. And last but not the least, we have Dapa Ckd. Again, I won't go into too many details on this study, and it's unusual for cardiologists to come together and talk about using a drug in CKD. But as you can imagine, the SGLT2 inhibitors have had such a drastic improvement in major cardiovascular event benefit and improved renal function. You will hear more about the renal benefits of SGLT2 inhibitors in our next episode, as I previously mentioned. So I will briefly go over the results of Dapa Ckd. The clinical question was really whether or not in patients with and without type 2 diabetes and chronic kidney disease, defined by either GFR reduction and macroalbuminuria, does dapagliflozin affect the progression of chronic kidney disease and cardiovascular death? Now, if you've looked at Credence, which is one of the other studies that looked at renal outcomes in patients getting canagliflozin, it was a very positive trial published last year in 2019. Sort of got the ball rolling in how you can use SGLT2 inhibitors to improve renal function in this group of patients with chronic kidney disease. 4,304 patients. It's a multi-center double-blind randomized placebo-controlled trial. 450 study sites over 20 countries, mean follow-up of 2.4 years. I believe this was the first time, or one of the first times, that a trial was stopped early in the CKD patients for benefit. So it was started early because there was significant benefit in the treatment group. The primary endpoint was a decline of more than or equal to 50% in eGFR, new end-stage renal disease, renal mortality, or cardiovascular disease mortality, and it was 9.2% in the dapagliflozin arm versus 14.5% in the placebo arm. Hazard ratio 0.61, p-value less than 0.001, number needed to treat of just 19. You may also know that the GFR cutoff for inclusion in this trial was as low as 25. So now we've gone beyond our previous cutoff of 30 to now 25 GFR, where you can get people in on the study. And these patients were already on ACE and ARB, which we know has some benefit in this group of patients with CKD. It was on top of background therapy. Those with type 1 diabetes were excluded. Organ transplants, NYHA class 4, recent MI or stroke, recent bypass or stent were all excluded. Active malignancy, serious medical conditions that would decrease your life expectancy to less than 2 years or serious hepatic impairment were all excluded from this study. If you look at the patients, it was 62 years old, mean age 33% female, mean BMI 29%, blood pressure roughly 137 by 77, mean GFR was only 43 to get in this study group. 14% of all patients had a GFR of less than 30. Most of the patients were group 3, roughly 76% of these patients. And then urine albumin to creatinine ratio was 965 milligrams per grams, and a ratio of more than 1,000 milligrams per gram was present in 48% of the patients. 68% of the patients had diabetes. 32% did not have diabetes. So as I said, there was significant improvement in renal outcomes and cardiovascular disease mortality, the combined endpoint. In the breakdown, a lot of the benefit comes from the renal aspect of the endpoint. The CVD mortality was 3.0% versus 3.7% in both groups. Hazard ratio 0.81, p-value was more than 0.05. But when you looked at either decline in GFR or new end-stage renal disease or even renal mortality, you can see all these endpoints favored using dapagliflozin. The heart failure hospitalization was significantly lower in the group of patients that received drug, again consistent with the early trials. If you look at EMPEROR outcome or DECLARE, TIMI, or CANVAS, this is sort of consistent across that. And here's the other punchline: all-cause mortality, even though it was a secondary outcome, was significantly lower in the group that received the drug, 4.7% versus 6.8%. Hazard ratio 0.69, p-value 0.004, number needed to treat of 48. No serious differences in adverse events, no changes in amputation, no changes in discontinuation of drug, no renal-related adverse events, no significant changes in fractures. Couple of things that favored placebo was the rate of major hypoglycemia was slightly higher in patients that received the drug, 0.7% versus 1.3%, p-value 0.04. The number needed to harm, 166. Something to just watch out for. And I guess as you can imagine, volume depletion was also slightly more prevalent in the group that received dapagliflozin, 5.9% versus 4.2%. So outside of these two side effects, really slightly more hypoglycemia, slightly more volume depletion, really the major adverse events, no different. Now, one of the criticisms of the trial is that it was stopped early due to data showing benefits, so it may have led to underpowering of less common endpoints. Again, almost all patients were on an ACE or ARB, so it's unclear if there's a benefit to adding dapagliflozin for patients with CKD who are unable to take an ACE or an ARB. And patients needed at least some microalbuminuria to get into the study. So if you have somebody with CKD but no microalbuminuria, not really studied in this trial. It's something that we'll talk about in future episodes, but I can tell you the renal community is extremely excited about these results and extremely excited that they finally have a drug class that slows down CKD, and not only slows down CKD, but actually improves survival. That's all we have for today's episode. I'm going to close it with this last trial. Please feel free to look us up on all our different websites and comment on what you thought about our episode. We'll follow this up with a multidisciplinary discussion, and then I'll follow this up with discussion on the trials that were presented at the American Heart Association, because there was some really good stuff there too.
If you enjoyed our episode, don't forget to like, subscribe, and give us a high rating, as it helps other listeners find us. You can leave your suggestion for topics, critiques, things you think we can do better. You can email us at heartsuccessteam@gmail.com. You can actually find us on our website at www.heartsuccess.info. Our website now also provides links to all the podcast providers where you can listen to this episode. You can find us on our Facebook page at Heart Success Team, or you can always reach me on Twitter at CardioBro.